K file which you will have to use for the first time. Done for the anterior, followed by only this black file. Done. So 20 anteriors you can do. You want me to repeat the sequence? Axis opening in molar, 15 size file, red file in mesiobuccal, mesiolingual. Distal canal, 15 size file followed by red and blue. Done. Molar preparation. Anterior, 30 size K file followed by black. That's all. Any doubts? Any doubts? Before I go to the next slide. Imagine you have only one files. In the red, black, there is one file now. In the red followed by blue for the molars. Only black for the anterior. Black. But for distal we need to red and blue. நீங்கள் நல்ல ட்ரெயின் ஆகிட்டீங்க. If you are good at hand file, you can place blue also directly to distal, but you should be properly trained. For initially when you start, use red followed by the blue. That is, to be very honest, it has been designed for narrow canal, wider canal, anterior canal. Narrow canal is for your mesiobuccal and mesiolingual, wider is your distal, black is for your anterior. அவ்வளவுதான். 20 cases you can use, 10 cases you can use it with one set. If you are not going to invest in your endomotor, you wanted to go in your hand file system, this for pulpectomy, this is the only file system which is available for hand file exclusively for primary teeth. Can I move on to the next file system or clear with hand files? Next. So with this, in 2016 we launched the first pediatric rotary file. It is all files which is control memory should be done in lateral swiping motion. Lateral swiping motion, na? Imagine that's a mesiolingual canal. This is your furcation region. You should swipe away. இந்த பக்கம் swipe பண்ணக்கூடாது. Swipe away from the canal. Proximal side, towards your buccal side, not towards your furcation region. Any rotary file when you use, you should swipe away from the canal. Or the away from the furcation region. Everybody will swipe சுத்தி பண்ணிட்டு இருப்பான். You should always, for example, this is mesiobuccal axis opening. This is your furcation region. Go away and swipe. Don't come in. Am I clear? See, 15 size K file போட வரைக்கும் it will take the path. The 15 size oda velaye, it should negotiate the canal. You wanted to curve, you can curve. You wanted to put in tuck, anyway it takes. It doesn't make any sequence. அதாவது primary teeth, permanent teeth மாதிரி primary teeth இருக்காது. It is like just entering inside slow, அப்படியே லூஸாக போயிட்டு வரும். Especially when you treat a kid who is less than 6 years. Pulp chambers are wide. 15 size file ஈஸியாக போயிட்டு ஈஸியாக வந்துடும். Understood? ஏன்னா பெர்மனன்ட் டீத்தில் வந்து நல்லா டைட்டாக போய் ப்ரீ கவர் இதெல்லாம் அழகாக போயிட்டு வந்துடும். 6 and 7 இயர்ஸ்க்கு மட்டும் யூ வில் ஃபீல் ஸ்லைட் ரெசிஸ்டன்ஸ், பட் இட் வில் கோ. Both you can do. Both you can do. You want to take working length, yes, but you will have to keep 1 mm short of the apex. Rotary போடும்போது, if you take working length for primary teeth, keep 1 mm short of the apex. No, in primary it is swiping motion. Manufacturer's recommendation for the rotary file or the hand file is swiping motion. Ideally speaking, control memory files are to be used in swiping motion. Control memory, I'll tell you what is control memory files. Okay? The hand files are done. Next will be your pediatric rotary file. There are so many generations in pediatric rotary file. I will let you know what exactly is one second. Have you seen pro taper files? First file. Whoever's used pro taper, first silver color or file varum. That is the first generation of pro taper files. When you bend, it comes back to its original position. What is that called? Shape memory. Okay. That is plain nickel titanium shape memory files. It is good or bad? Simple question. Shape memory is good or bad? Bad nu sonna rotary file poch. All rotary files will have shape memory. There are only two concepts. One is shape memory, one was control memory. இது ரெண்டுலத்துல மட்டும் தான் they are playing. Control memory na when you bend it stays in the original position. Now I will give you two options. When I bend it goes to the original position. When I bend it stays in the same position. Which is good, which is bad? These are all the scenarios. See, rotary file is playing. See, I will tell you what. Now people are doing adult rotary, right? Now there is something called Pro Taper Gold. Why did you ask? I want only silver color file. Why you changed to Pro Taper Gold? When control memory is there, fracture reduces. Right? Shape memory capacity will have aggressive preparation and it will fracture more compared to control memory. Flexibility is more. அதே கம்பெனிகிட்ட போய் நாங்கள் சைனாலேருந்து நிறைய ஃபைல்ஸ் வாங்குகிறோம், எல்லாம் ப்ளூ கலரில் வருது, நீங்கள் ஏன் ப்ளூ கலர் ஃபைல்ஸை மேனுஃபேக்சர் பண்ணலன்னு have anybody is asked? Pro Taper company does not have this blue color files at all. யாராச்சும் வந்து நான் ப்ரோ டேப்பர் கம்பெனிலேருந்து வரேன், இது ப்ளூ ஃபைல்ஸ்னு உங்கள்கிட்ட கலர் ஃபைல் கோல்டோட இது பெட்டராக இருக்குன்னு யாராவது சொல்லியிருக்காங்களா? There are other company files which is coming with blue technology, but this particular Pro Taper company has not done this blue technology. Think, I will come back. Next, you see this, that's the first generation file which will be silver in color. We stopped that particular file. Now SG, SG Blue, S Square and S Plus is available. This is the second generation, third generation, fourth generation and fifth generation. You will have to only tell me why generation wise we developed. Now, same concept in silver I bought, now it is in golden color. Silver is shape memory, gold is, meaning this particular SG is golden color. So this has control memory. So fracture is less. Same concept but blue coated. This blue coating is because of titanium oxide coating. Titanium oxide coating will reduce the fracture, increase the cutting efficiency. Correct? Understood? Blue technology will reduce the fracture, slightly increase the cutting efficiency. SG Blue. SG Blue is the gold standard for all pediatric rotary file which is available in the entire market. Now you see single file system, one file for molar, one file for anterior. ஒரே ஃபைல் தான் molar இருக்கு, ஒரே ஃபைல் for anterior. Now this color coded you see, red, blue, black. Red is for tip 25, 30, 40. 25, 30, 40. Now there are two bands, two colors. Why? Single system. Now what do you mean by these two bands? (25, 30). The file tip size meter is in between 25 and 30, which is 0.28. Green and black, between 35 and 40, the tip diameter is 0.38. Only if I can adjust this particular tip diameter, I can make it, which means I mixed these two files and made one. Mixed 35 size and black and made one. Now any endodontist here? Endodontist. Okay. Usually I don't talk when there is endodontist because periodontists are. No. That's a simple. ISO standardization of manufacturing rotary file says 15, 20, 25, 30, 35 should be the tip diameter. I have bypassed and kept 0.28. Right or wrong? It is right because it is there for the longer time. You don't answer, ma'am, because I think you got the answer. Anybody else? I have bypassed the tip diameter of 0.25, 30, 35 and I have kept this particular diameter as 0.28 and 0.38 and I have manufactured one particular file. According to endodontists, they will not accept because you will have to follow the ISO standardization. I am not worried about it. Right or wrong? If it is right, why? Don't think too much. Very, very simple. After so many lectures I have given, This is the first answer I'm getting. We do not need a tuck back, and I'm not worried about GP. I can have 28, 29, 30, whatever it is, because I'm obturating with the paste. That's why we are able to make one file system for primary. Now you see gold and blue. Why? Flexible. This is coronal. Why? Coronal is gold. I asked you one question, why ProTaper companies not come with blue files? Take it in your mind. As the flexibility of the file increases, cutting efficiency decreases. As the flexibility of the file increases, cutting efficiency decreases. In permanent teeth, you need cutting efficiency. Primary teeth, you need less cutting efficiency. Here, less preparation apical, but coronal, I want a good preparation so that my obturating material is flowing in. That's why that file is there. 4 files done. 15 size K file followed by red, done. 15 size K file followed by red and blue in distal, done. 30 size K file followed by the black, done. Rotary file preparation, I'm telling you, like similar to your hand files. So this will take 2 minutes, not 2 minutes, 30 to 40 seconds. This will take 40 seconds. Your molar preparation is done. This only one file, 40 seconds it will take and prepare. Whenever you put it inside the canal, you will have to swipe 1, 2, 3, 4. 4 times, 4 to 5 times maximum swiping till the working length. End of the story. Done? Same here. Here no problem, no changing the file. Do access opening, 15 size KL file, molar, swipe it 5 times, finish. Swipe the anterior 5 times, finish. Same here. Understood? There is one file which will never break in primary. Okay. SG blue only you're using, no? Yeah. This is this latest generation. It is nano. It is one file for molar, one file for anterior. We recommend it for 14 molars, 14 incisors. Okay. Now you do an access opening. Say example the child is 4 years old. You do molar and prepare with one file. Still in palatal tissue there is some pulpal tissue. What you will do? You've done access opening in 4 year. Mesobuccal, mesolingual and palatal. Distobuccal and palatal is there. You put these 3 files because we recommend only one file. And all the other 2 canals, pulpal tissue is out. You can see no bleeding. Palatal you feel there is pulpal tissue. What will you do? It will not come. Use the black. Consider that as an anterior canal. Use the black and finish the preparation. Understood? Especially in your less than 5 years old, your palatal canal is like your anterior. Simple application. With these 2 files when you use, irrespective of whatever age, the pulpal tissue will come. Any doubts about rotary? We made it very simple. Anything else? All the rotary file systems to be used in endomotor only, which has a reverse, anti-reverse which is available, and 300 RPM, 2.4 is the torque. 300 RPM, 2.4 is the torque. Clockwise rotation, if you have this anti-clockwise, what do you call that? Some row. I forgot. Yeah, reverse active. Usually it is there in XMAT. Nowadays it's coming with all the endomotor. Any doubt here with rotary? This is the 6th generation. Okay. Any doubts? I'll go through because now you are confused to use which system. I'll tell you what it is. In 15 size file is more than enough to take it. 15 size file, if you feel it is very loose, then use the 20. Use the hand file and apex located, there it will read. See the root ZX, the thing it responds. Even with hypochlorite, it will respond in some time. It will respond. See, even in your primary teeth, after you put a permanent teeth, after you put a file, take working lenses, there is pulpal tissue which is down. It will give the reading if you use a good apex locator. Especially with your lower D, there is three rooted. When you take an X-ray, when you feel there is one root, in between there is one root, and then one root, which is like this. You should expect two canals in the molar, two canals in the distal, and one canal in the anterior. One canal in the mesial aspect. If you see this three rooted, this is your distal side and that's your mesial side. It will be reverse. You will have two orifice opening in distal and one orifice opening in the two orifice in the distal and one in the mesial. It's like reverse it will be. Usually the distal has one orifice, mesial will have two orifice. But in this particular case, distal will have two orifice, mesial will have one orifice. That is the most commonest variation in primary molars or single rooted. But incidence, if you ask me, 4%. Am I clear? So I will give you one good comparison. We'll go like this. Just check the red color alone. 2 files for molar, 2 files for molar, 1 file for molar, 1 file for molar. Just check the red, that is the advantage of that particular file system. 1 file for anterior, 1 file for anterior, 1 file for anterior, 1 file for anterior. No advantage at all the same. Heat treated with titanium oxide, 50% heat treated, 50% not heat treated. Correct? Next, control memory, no change. 8 molars, 8 incisors, 12 incisors, 12 molars, 12 molars, 12 incisors, 12 molars, 12 incisors. Conservative apical preparation, and coronal preparation, and you have coronal more wider in S+. This is the comparison chart. As of now, if you are doing it for the first time, I will tell you from where to start and where to end. So this is the 5 file system comparison. We have one more comparison, which is this 6th generation, 1 file for molar, 1 file for anterior. Carbon nano coating, this plays very important role. That's why I have made it little. Carbon nano coating is one which is actually making the file not to fracture that easily in this particular thing. Conservative apical and coronal preparation. Now to start, if you are using it for the first time pediatric rotary file, I would advise you to start with SG Blue. Mesiobuccal, mesiolingual, distal and anterior. First time, SG Blue. You will have less fracture. You might not even have fracture at all. That is for your. Once you are okay with this, you can either change to S square or nano. Single file system. That is up to you to choose. Because people who started with SG Blue never changed to other style system. People who started with S square never changed to other system. People who started with nano never changed to other system. It is up to you to choose which one is suiting for you. Done? Anything else? So these are the articles which has been there for publication. You can just type Kido files in Google, you will get around 73 articles till date. This is the observation which you can get with the rotary files. Okay. Now I would like to. In case if it is young kid and you feel the pulpal tissue is not at, use the anterior and finish it off. Done? Am I clear? Number 1. Most commonest problem is the fracture when you do an access opening or perforations. You have something called EX23 burr. It is very short shank. It will not go and touch. Unless you chop off this particular coronal region, it will not go and touch the furcation region. So with round burr, you remove all the decay. With this particular tapering, do an access opening. 1 burr for both. EX23, this can be used for primary teeth. Second, whenever you are taking working length, kindly have a standard reference point. Oru cusp mele, oru cusp keele, you will have variations. You might miss. have a standard reference point, because in primary teeth, anyhow you are going to give a stainless steel crown when you take working point. Second error. Third, have a good spoon excavator and remove the coronal pulpal tissue properly. You would have done access opening pannittu, take 15 size file, keep on searching where is the canal. File is bent. One more you take, keep on search, file is bent. And you say file is manufacturing is not proper. It's not like that. Remove the pulpal tissue with spoon excavator. Obviously, you will see 3 points of bleeding. Use that. Done. Inspect the file. H file is there, K file is there. H file, if you are not used to it, don't buy. You can have K file. But in primary teeth, never buy this hand nickel titanium file. It is of no use. Hand 2% file, nickel titanium files will come. It will bend. Not required for primary teeth. K file is more than enough. H file, if you wanted or you are confident, you can use. This is the study which shows that K file, H file, everything has a good preparation and obturation. Inspect your file after every case. This is the most commonest thing. This, if you see, if there is something which is unwinded at that particular area, which means it's a sign of going to fracture. You know it is going to fracture, discard. You can even see elongation. Remove, throw the file. You always have to inspect the K files. Nowadays, we see more amount of K files breaking than rotary files. Be careful. I don't know what it is, but be very careful. Sodium hypochlorite. It's called 3-drop technique. You've done access opening. 3 drops is drop. 1, 2, 3 in mesiobuccal, 15 size K file. 3 drop in mesiolingual, 1, 2, 3 mesiolingual 15 size. 3 drop in distal 15 size. Then you take 1 ml of saline, irrigate. Then again 3 drop of sodium, drop is drop, followed by D1 file. 3 drops followed by D1, the red color file. 3 drops followed by D1. Irrigate with 1 ml, irrigate with 1 ml. Again your distal you have to use blue color file, use 3 drops, blue color file. Understood? Your rotary files. So every file which you use, you will have to use 3 drops of sodium hypochlorite, 1 ml of saline. Finally, it is 2 ml of saline for each canal thoroughly. Am I clear? 1 ml after each instrumentation, 15 saline. 3 drops of sodium hypochlorite after before each instrumentation. Any doubts? Drop will not irritate at all. If you flush, it will. The concept of that's all. Drop will not, drop is drop. I am telling you drop. Drop it. You don't flush it. Drop it. 1, 2, 3. It was never. Can you show me one case with sodium hypochlorite? Accidents are there. Permanent tooth lende perisa irukku we cannot see at all. Developmental stage liye problem vandirukkalam. There is no proof. And sodium hypochlorite drops irrigate panna might. Now people are irrigating also, but I advise you to go for drops. Super, ma'am. Irrigation is okay. Saline is okay. All rotary instrumentation coated with EDTA gel, more than enough. Hypo? Yes, nothing. Hypochlorite and sodium hypochlorite and chlorhexidine only should not be mixed. This will not cause impact. Irrigating tool, ma'am. What is this? Super. Anybody else? நம்ம காஸ்ட்லியே கிடையாது, நம்ம ரொம்ப சீப்பான ஆள். நாட் வெரி எக்ஸ்பென்சிவ். அதெல்லாம் ஒன்றாக. மெட்டாபெக்ஸ்னு வாங்குறீங்களே அதோட டிப்பு தெரியலையா? ஓகே, அதானே ம் இல்லை தெரியுதா? இங்கே தான் தெரியல, எங்கே இருக்குது பிக்சர்னே தெரியல. தட் இஸ் அண்ட் நீங்கள் மெட்டாபெக்ஸ் சிரிஞ்சோட தே கிவ் 20 டிப்ஸ். அதில் நாங்கள் ஒரு டிப் தான் யூஸ் பண்ணுவோம். அந்த டிப்பு காலி ஆகிற வரைக்கும் அதே ஒரு டிப்பை கட் பண்ணி யூஸ் பண்ணுவோம். 1 mm கட் பண்ணுவோம் வரும், திருப்பி 1 mm கட் பண்ணுவோம் வரும், அப்புறம் நல்லா கட் ஆகிடும் மோலார் குலர் போகுது, அதை ஆன்டீரியர் யூஸ் பண்ணுவோம். I would advise you to use the remaining tip in irrigate. That is more than enough. Okay?
Even ICO also we have to
Drop.
feed off with that.
Drop. Yes. Adhe tip you can use it also for saline. Nothing happens. The paper point use பண்றது is an art. எப்படின்னா ஒரு பேப்பர் பாயிண்ட் எடுத்து டக்குன்னு கெனாலுக்குள்ளே வச்சுட்டு கதை பேசிட்டு இன்னொரு பேப்பர் பாயிண்ட் எடுத்து அது என்ன ஆச்சுன்னு தெரியாமல் எடுத்து வச்சுட்டு இன்னொரு பேப்பர் பாயிண்ட்டை வச்சுட்டு ஒரு கதை பேசிட்டு வரும்போது அப்படியே டேபிளில் பார்த்தா 1 2 3 4 பேப்பர் பாயிண்ட் 2 கொஞ்சம் ரெட்டு கொஞ்சம் ரெட்டு கொஞ்சம் ரெட்டு கொஞ்சம் ரெட்டில் இருக்கும். When you place the paper point, I would advise you to buy this F1 and F2 if you're using a rotary file. அதில் F1 paper point, place it inside the canal, wait for 30 to 40 seconds. உங்களோட பேப்பர் பாயிண்ட் இங்கே வெட் ஆச்சுன்னா it is absorbing. எப்போ நீங்கள் பேப்பர் பாயிண்ட் யூ கீப்பிங் இட் இன்சைட் and it is still remaining dry at the top region, which means the canal is dry. Dot. You understood? I keep a paper point, but my coronal aspect is not getting wet, means your canal is dry. புரியுதா?
Same for permanent.
Only pediatric dentistry. But there can be chances of tip being with moisture or red color bleeding, which means you would have extruded whatever it is. But my paper point is not getting wet when I place it for more than 30 to 45 seconds inside the canal, is directly proportional to my canal being dry. If it is class 2 cavity, I advise you to give a GIC restoration and a crown. If it is class 1 cavity, you can give a temporary sealing and then a crown. This is your crown, which is mandatory. Okay? Just crown, stainless steel crown. Ma'am, this is a class 1 cavity. 4 வாலும் இன்டாக்டாக இருக்குன்னா நீங்கள் டெம்பரரி ரெஸ்டரேஷன் வச்சுட்டு க்ரௌன் போட்டுக்கலாம், நோ ப்ராப்ளம். ஒரு வால் இட் இஸ் broken for class 2 னா it is always better to give GIC and then give a crown. It is, ma'am. Especially if you are going to stay for 3.5 years on the tooth, give for a crown. நடக்காமையும் போகலாம். நான் ஜிஐசி கொடுத்து பேஷண்ட் வராமையும் இருந்திருக்காங்க, அந்த பேஷண்ட்டுக்கு ரிசர்வ் ஆகி பல்லும் நான் எக்ஸ்ட்ராக்ட் பண்ணியிருக்கேன். இட் இஸ் நாட் நடந்துருச்சுன்னா அப்பயே சொன்னேன் நான் க்ரௌன் போட சொல்லி அப்படின்னு வீழ்த்தேன். Taper, the entire taper is different. You've seen pro taper, right? First 3 mm க்கு ஒரு taper இருக்கும், then it will progressively grow. It's called pro taper. அடுத்தது வந்து uniform taper files, constant taper சொல்லுவோம், 4%, 6% சொல்லுவோம். This is variable taper. Every mm of the file will be different taper according to the primary teeth. That's the reason why we have got patent. இல்லைனா அது அப்படியே adult fileோட காப்பியாக இருக்கும். Every mm of the file 4% இருக்கு, 6%. Again it comes to 4% because there will be maximum curvature in that particular area. அதை calculate பண்ணி we have designed this. Actually 2/3 of the இது வரைக்கும் preparation வரைக்கும் போய் நீங்கள் plug பண்ணாலே if your canal is dry it will fill and come out. Nothing. Extrude ஆயிடுச்சுன்னா you are over prepared. பண்ணலை அந்த எபிக்கல் பேரேஜ் பிரேக் பண்ணலன்னா அது அங்கேயே நின்றும், நின்றுட்டு இட் வில் கம் பேக். நீங்கள் அட் டைம்ஸ் பார்க்கும்போது இன்ஜெக்ட் பண்ணும்போது அப்படியே டிப்போட ஒட்டிக்கிட்டே வரும், அப்படியே இன்ஜெக்ட் பண்ணிட்டு வெளியே யூ ஹேவ் டு டேக் அ காட்டன் அண்ட் கம்ப்ரெஸ் இட். இட் வில் கோ, அவ்வளோதான் போகும், என்ன தான் ஒயிட்டாக இருந்தாலும் அவ்வளோதான் போகும். Anybody here practicing pediatric dentistry? Child. I tell this to my PG students. நீங்கள் பெஸ்ட் யூஸ் இன்ஸ்ட்ருமெண்ட்ஸ் யூ கேன் யூஸ், பெஸ்ட் இரிகேஷன் யூ கேன் கிவ், வேர்ல்ட்ஸ்லேயே பெஸ்ட் ஃபைல்ஸ் யூ கேன் யூஸ். பட் இஃப் யுவர் கிட் இஸ் கோயிங் அவுட் வித் டியர்ஸ், யுவர் ட்ரீட்மெண்ட் இஸ் எ ஃபெயிலியர். நான் பார்த்துருக்கேன் பிஜிஸ் என்ன பண்ணுவாங்கன்னா ஒரு நாளைக்கு 10 கேஸ் பார்க்கும்போது they will also get frustrated. அப்படியே க்ரௌன் அழுத்துட்டு வாஷ் கூட பண்ணாமல் வெளியே போகும்பாங்க, எனக்கு child will be crying. That is a failure. According to people who are seeing outside is a failure. உள்ளார என்ன வேணாலும் இருக்கலாம். You would have done an under observation also. அது கூட is okay. But this managing kids in chair, sending them without tears is the pediatric dentistry what we teach. That you will have to follow. That's what we call it as success point. Done? Any other doubts? We are done with lecture. Every year once, ma'am. It doesn't come that easily out. Stainless steel crown is a big advantage. All pediatric dentists are very happy with stainless steel crown is because once உள்ளார போயிடுச்சுனா it will not come out. Nothing will happen. அது அப்படியே கடிச்சு நாங்கள் என்ன பண்ணுவோம், ஜிஎல்லாம் பண்ணால் அக்ளூஷனே வி டோன்ட் செக். கடிக்கும் போது ரெண்டும் அப்படியே ஓப்பன் பைட்டில் இருக்கும். அடுத்த ஒரு வாரம் கழிச்சு பேஷண்ட் ஈக்குவல்னா எல்லாம் அக்ளூஷன் இருக்கும். தட் மேலிபிலிட்டி, அதனால தான் ஸ்டெயின்லெஸ் ஸ்டீல் க்ரௌனை பிரேக் பண்ணுறதுக்கான எந்த க்ரௌன் வந்தாலும் இட் இஸ் நாட் பிக்கிங் அப். Zirconia, we still do zirconia, but only for the anteriors. I have my kit, anterior zirconia, posterior stainless steel crown. எனக்கு ஸ்டெயின்லெஸ் ஸ்டீல் க்ரௌன் ப்ராப்பர்ட்டிஸ்லேயே ஒரு ஒயிட் கலர் மெட்டீரியல் வந்தால் ஐ வில் டேக். அந்த பயோஃப்ளெக்ஸ் அதெல்லாம் இப்போ பெரிய கம்ப்ளைண்ட் ஆகி கேஸ்லாம் போயிடுச்சு. அது என்ன ஆச்சுன்னா, அது கடிக்கும் போது அது தூள் தூளாக ஆகுச்சு. அப்ராடில் லாட் ஆஃப் கிட்ஸ் ஸ்டார்டட் சூவிங் இட் அண்ட் டேக்கிங் இட். அதில் இன்னொரு ப்ராப்ளம் என்னன்னா, நீங்கள் அதை எக்ஸ்ரே எடுத்தீங்கன்னா இட் வில் நாட் பி சீன். அது ரேடியோ ஒப்பேக் கிடையாது, ரேடியோ லூசன்ட். ஸோ அது உள்ளார போய் என்ன பண்ணுச்சுன்னு இப்போ எனக்கு கொடுன்னு அவங்க பேரண்ட் எல்லாம் அங்கே கேஸ் போட்டுரு. அதனால் அந்த க்ரௌன் அப்படியே ஸ்டாப் ஆகிட்டு. இட் வில், ஐம் டெல்லிங் யூ, சிமிலர் ப்ராப்பர்லி வித் ஸ்டெயின்லெஸ் ஸ்டீல் க்ரௌன். இதே ஃப்ளெக்சிபிலிட்டி வெள்ளை கலரில் இருக்கணும், மெட்டல் மாதிரி. நான் கிரிம்ப் பண்ணால் நானே கிரிம்ப் பண்ணும். இந்த அமுக்கிற இதில் அதெல்லாம் அமுங்கும் போது இட் வில், இஃப் எனி திங் விச் இஸ் டூ மச் ஃப்ளெக்சிபிள் இஸ் வென் யூ கிரைண்ட், இது காமன் இது இல்லை. தட் இஸ் வாட் தட் கிட்ஸி க்ரௌன் டின் பிக்கப். அதுவும் இல்லாமல் அது சாக்கி ஒயிட்டாக இருக்கும், போட்டிங்கன்னா நல்லா தெரியும். அப்படியே வெள்ளை கலர் சுண்ணாம்பு அடித்த மாதிரி இட் வில் பி லைக். ஸோ ஆஸ் அ பீடியாட்ரிக் டென்டிஸ்ட் வி ஸ்டாப். எங்கள் காலேஜில் வி காட் இட் ஃபார் 2 lakhs சம் இண்டியன் வி காட் இட். அப்படியே திருப்பி கொடுத்துட்டு நீங்கள் ஜிர்கோனியா கொடுங்கட்டோம். ஜிர்கோனியா இஸ் பெட்டர். அதுவும் ஆன்டீரியர் ஸ்டெயின்லெஸ் ஸ்டீல் க்ரௌன் இஸ் தி பெஸ்ட் ஃபார் தி போஸ்டீரியர். லெஸ் எக்ஸ்பென்சிவ். அப்படியே வந்து அவங்க வந்து எனக்கு ஜிர்கோனியா தான் வேணும், எனக்கு ஒயிட் கலர் தான் வேணும்னா, இட் இஸ் பெட்டர் யூ கோ ஃபார் ஜிர்கோனியா தென் அதர்.